Yeah, good evening, everybody. Students, this week we shared the resources on management of a newborn with asphyxia. How do you manage such a baby in NICU? And the second topic of this week was management of neonatal seizures. So we have Dr. Amit Upadhyay sir with us today, this evening. Sir is the head of department and director at Newtima Hospital and trained neonatologist from AIIMS, New Delhi. Welcome, sir. We can start.
Very good evening, Dr. Fatima and everybody. And today is a very important topic because almost 1/4 of all our babies who are admitted or who die are secondary to asphyxia. So prevention of asphyxia through NRP is one separate topic. And today we are dealing with babies who develop asphyxia. How do we manage them? And we all know that seizures is a common part of the syndrome of perinatal asphyxia. And how do we manage neonatal seizures? We also shall deal with that. So first and foremost is post-resuscitation management of perinatal asphyxia. It is aimed after resuscitation, after the steps of NRP, when you have ongoing care inside the NICU shifted, then what all do we do? We begin from that point. Next. So perinatal asphyxia is the second most common cause of neonatal death after infection, accounting for almost 30% of all mortality worldwide. That could be a little bit more in Indian scenario. Learning objectives are to perform initial stabilization and management of asphyxiated neonates. How do we monitor an asphyxiated neonate? And how do we recognize poor prognostic factors in perinatal asphyxia? Asphyxia is a bit difficult to define most of the times. And it is basically ineffective breathing, which manifested as either no respiration at all or gasping respiration, which is there at 1 minute of life. So you give first 1 minute for stabilization for intrauterine transition from intrauterine to extrauterine life. If even at 1 minute there is gasping breathing or no breathing, then we label it perinatal asphyxia. Need for, sorry, just please reverse the slide here. It is also defined as need for positive pressure ventilation for more than 1 minute. If APGAR scores at 5 minutes or more is less than 3. So 1 minute APGAR is less important. For definition of perinatal asphyxia, 5 minute APGAR, that is prolonged poor neurological score, is important to label it perinatal asphyxia. As already discussed, asphyxia is the second most common cause of death worldwide after sepsis. Next. So these all slides of definition are really very important for management involved in which baby do we label asphyxia, because this can have a medical legal impact as well. So one can't loosely label any baby with asphyxia. And also, if we label a baby asphyxia, then we have to monitor such babies. We label them as high-risk babies, and we have to monitor them subsequently as well in high-risk clinic, do their developmental follow-up. So it has more connotations in follow-up as well. So proper label or diagnosis of asphyxia is important. Moderate birth asphyxia is if so intramural babies, it is easier to diagnose asphyxia because baby is born in front of you. You are seeing the baby that he has not breathed soon after birth. He has required respiratory support or PPV in front of you. His APGAR score should be done by yourself, and you would know that if APGAR score at 1 minute is less than 7, so it is rather less than 7 at 1 minute is perinatal asphyxia. Moderate asphyxia is if their score is between 4 to 6 at 1 minute of age. Severe asphyxia is APGAR score less than 3 or equal to less than 3 at 1 minute of age. So intramural is easy to define. Everybody knows from MBBS days how do we do the APGAR scores, and based on APGAR you can give the definition of everything. Problem arises if the baby is not born in front of you. So in extramural babies, as we call such babies, moderate asphyxia is if you have gasping breathing or slow respiration at 1 minute of age. This extramural baby, you will not be there. So the parents or the attending doctor over there, he would have either given APGAR score if delivery at home or conducted by a non-medical person like ASHA workers. At times they could be the person resuscitating the baby. Then they would give that gasping breathing or severe birth asphyxia is if there is no respiration at all at 1 minute of age. So these are very hardcore signs that respiration, breathing is there or not. That is easy to diagnose. So there is no ambiguity. So all such definitions should have no ambiguity. That is, if there is slow breathing, it is moderate asphyxia. If there is no breathing, it is severe asphyxia at 1 minute. This 1 minute is important to know. Then ACOG and AAP guidelines. So they require, this is more field level definition earlier, which we had. Now, what is the scientific definition of perinatal asphyxia, which you do in neonatal ICU or in tertiary care centers? You need to have a cord pH, ABG done of the umbilical cord artery. So UAC, ABG, if the pH is less than 7, it could be metabolic or metabolic plus respiratory acidosis. If APGAR score of 0 to 3 for longer than 5 minutes, so that is despite some resuscitation, you would have begun your positive pressure ventilation, even given chest compression or prolonged positive pressure ventilation based on the respiratory effort, based on the heart rate, and neurological manifestations if they are there. That is very comatose, is obtunded, is hypotonic, is having seizures, and fourth, this hypoxia which is there has not only affected the brain, but also affected other organs like kidney, heart, liver. So multi-organ dysfunction is a part of this perinatal hypoxia definition. Neonatal manifestations like seizure, coma, hypotonia, poor APGAR scores, and poor pH. All these four have to be present to classify as perinatal asphyxia as per ACOG and American Academy of Pediatrics. So this is very scientific, intensive care type definition. Now
Mm.
WHO wants to give more field version of definition, and it is simply failure to initiate and sustain breathing is the WHO definition of the perinatal asphyxia. So you need to know all of these. Even one is important for one patient, but you all are first year postgraduate students. You all have to give an exam later on. You have to write theory and appear in practical exams. And so all such definitions would be important for you.
Yeah, maybe practically we can ask who are the babies they are taking inside. They can just keep on typing in the chat box also, just to involve them, sir. Whether they are taking the babies who have APGAR score of less than 4 at 1 minute, are they taking inside NICU for care? Can you just type it? Because ACOG and AAP definition is very intense, I think. Cord pH and all we do, hum karte hain. And then we decide for other interventions and all. So who all babies, if you all are posted in NICU, can somebody type in the chat box?
What was the
Who are the
question?
babies who you take inside? Do you take all babies with asphyxia? Okay, let them type, so we can move ahead, I think. Shashank, you can move the slide.
Okay, yes. So this is a slide which is what is post-resuscitative care. So this is the resuscitation flow chart which we all have seen. So yeah,
Yeah, I think there
the,
is a problem with the figure here, sir. Hai na?
uh,
So
the figure
basically, the
is
ones who
difficult to
require
read.
bag and mask for more than 1 minute, we define as
Yes,
post-resuscitative care. This flowchart was to show that somewhere in this blue box.
yeah.
Yeah, you
So
can move to the next slide.
clinic Yeah. So clinical monitoring and complications of perinatal asphyxia. So we need to assess the severity. For every disease, we need to know the severity. So is it mild, moderate, or severe asphyxia? One was by APGAR score, as we had earlier read. APGAR less than 7 or 4 to 6 or 3 or less for mild, moderate, severe. Then what clinical monitoring such babies require for vital signs of neurological signs and minimizing the damage, newer modalities. One which comes to my mind straight away is say hypothermia. Is it required? When is it required? Then how would we work up or investigate such babies? And parents always have a question about, okay, how will this affect my child in long run? So that is prognostication, as it is called. So how do we prognosticate such babies? So clinical monitoring is very important. And can we move on to the next slide? So what do we see clinically? Perinatal asphyxia, which all organ does it affect? It obviously, if the baby is hypoxic, then entire body is hypoxic. All the organs are affected in perinatal asphyxia, beginning not just the brain, but also kidney, heart, lungs. And outcome of asphyxiated neonate depends upon extent of multi-organ dysfunction. CNS involvement leads to seizures. It can lead to hypotonia. It can lead to coma or obtunded baby. So preterm and full-term baby, different areas of brain are affected. Now this is important for your theory question as well. That which parts of brain are affected in which type of babies. So you can see that neuronal loss is an acute sign. It is gliosis results because of that. Frontal cortex is affected in 13%. Caudate nucleus, thalamus. Thalamus is so commonly affected. Almost one third of all babies will have thalamus which is affected. Then global. So renal, other clinical presentation other than brain, renal injury is common hematological. In this, oliguria can occur or non-oliguric renal failure can also occur. Hematological, especially bleeding manifestations like deranged coagulation can occur. At times, thrombocytopenia can occur. And shock, which could be of myocardial origin, can be there, or even central CNS type shock can be there. Respiratory support, need for respiratory support could be there because asphyxial lung injury is there, fluid is retained inside, poor transition is there, so lungs could be affected. And finally, GI, because hypoxic gut tends to get gut ileus, hypoxic ileus, and they don't move forward. And thrombotic events can occur. So spontaneous intestinal perforation and other things also is possible secondary to asphyxia. Then how is the brain affected? So brain is affected most commonly, perhaps most commonly is the kidney which is affected. Brain could be first or the second at times. And grading of encephalopathy is important because mild grade of encephalopathy would have better prognosis. If baby has severe encephalopathy, then prognosis would be worse off. So Levine classification is a simplified version of Sarnat and Sarnat classification for perinatal hypoxia, which is quite detailed with almost 12 or 13 points you have to look at and score 0, 1, 2. Whereas in Levine's grading, only 5 points have to be looked at. And consciousness, tone, seizures, sucking, and respiration. These are the 5 things to look at. And then you score them mild, moderate, or severe. So mild and severe are easy to remember. In between, it is moderate. So consciousness, baby is just irritable. So baby is constantly crying. So crying at times, we say that, okay, babies do cry after birth, but these babies are consolable. These babies are cuddleable. And so if the baby is inconsolably crying, inappropriately crying, then such babies, it could be a part of perinatal asphyxia. encephalopathy stage 1, whereas in stage 3, baby would be deeply comatose. In moderate asphyxia, he would be a bit lethargic. Hypotonia is there in mild grade encephalopathy. No seizures are there in mild encephalopathy. Sucking is poor but is present. Respiration is always spontaneous. Such babies, they do not require ventilation. Moderate. Pardon?
Shashank, will you be able to mute everybody?
हेपेटाइटिस ए भिजवाना है ये दूसरा चार्ट निकालो ठीक है ये भिजवाओ हाँ
Or are you sharing the screen? Can you mute everybody, please? Yeah.
So in moderate asphyxia, the baby is lethargic. He has marked hypotonia and seizures are present. So as soon as seizures are there, seizure is something which you can have confusion whether the hypotonia is mild or marked. You can have confusion whether baby is lethargic or comatose. How is the suck? You can have controversy, but there could be no controversy into seizures, which is very objectively visible sign. So if seizures are there, you can just simply say it is moderate perinatal asphyxia at least. Respiration here could be irregular or periodic. Once you have a baby who is comatose, that is non-responsive, then this is severe hypoxia. Such babies are absolutely flaccid. You raise their hand and it just falls under gravity immediately. And seizures here are uncontrolled. You may require multiple 2, 3 drugs to control seizures. There is absolutely no sucking, and such babies have difficulty in sustaining prolonged, sustained, spontaneous respiration. So most such babies end up in on either CPAP or probably getting intubated and ventilated. So this is very important slide. If anybody has any query, can raise your hands or put the question in the chat box, and we would be very happy to answer that. Next. Then you have Thompson score. So this is a little bit more um, detailed in this. Tone is there as it was there in Levine. Level of consciousness is there. Posture is there. Sucking and respiration. So these tone, consciousness, fits, suck and respiration were there. What is extra over here is posture, morose, grasp reflex, and fontanelle. So these 4 things you can remember that 2 are neonatal reflexes, morose and grasp. Then one is fontanelle. Fontanelle we all love to palpate in small children. So instead of 3 columns in Levine, there are 4 now. So 0 is no. So mild, moderate, and severe one can say as 1, 2, 3. 1, 2, mild, moderate, or severe of Levine is 1, 2, 3 of Thompson score. So tone, now this is going to create a bit of confusion because in Levine it was hypotonic. Sorry, can we go to the previous slide? Yeah. So in tone was hypotonia, right? From hypotonia, marked hypotonia, and severe hypotonia. Whereas, can we move on to the next slide? In Thompson score, there is hypertonia in mild grade, and hypotonia or flaccid is stage 2 or 3. Level of consciousness, hyper alert is same as irritable over there, and lethargic and comatose is same. Fits, no fits were there in first stage over there, but some fits could be there, but never more than 3, more than 2. In more than 2, then stage 2. And if it is refractory, then it goes probably in stage 3. Posture is new, fisting, cycling. You can take screenshots or you would be getting the lectures in any case. So these are important. You need not memorize them. You can have a just a poster of this placed in your case sheet or on your NICU notice board. And each of the babies should be marked as per this. And serial monitoring can be done every 12 hours. You can score such babies and you can see the progression of encephalopathy in such babies. The baby who is, hypertonic initially at 6-8 hours could be hypotonic by the time he reaches 48 to 72 hours. So there could be variation in the score with time, and that has to be documented in your case sheets. You do it on 10 babies and you will start remembering all of it. Maximum score is 22, that is the worst score. A score of 15 or more is shown to have positive predictive value of 92% and negative predictive value of 82% for abnormal outcome at 12 months of age. So now that is the important thing to remember. So, sorry. So, abnormal outcome at 12 months, a score of 15 or more. Remember this number. This is important. 15 or more. Next. And so these are basically the parameters of which are also there in SARNAT and SARNAT scoring, level of consciousness, neuromuscular control, complex reflexes, autonomic function, seizures, EEG findings. So these 6 can be classified into different mark points. Next one. So after this monitoring and scoring of severity, we need to look at clinical care, and clinical care is supportive care to maintain temperature, perfusion, respiration, and metabolic status like glucose, calcium, and pH, and nutrition. And therapeutic hypothermia should be initiated if at some centers there are facilities for this. So initial stabilization and management, first and foremost, TABC is TABCD, D for diet, you can say. So that is most important for the standard care of preterm in any condition. Same is true for asphyxia. So temperature one should maintain between 36.5 to 37.5. Therapeutic hypothermia to be given if facility is available. Airway is to be maintained by keeping the baby head in the uh, mid middle position, not too much flexion, not too much extension. Clear the secretions. Appropriate positioning by either keeping a shoulder roll, but just never put a pillow type structure under the head occiput. Otherwise, extreme flexion can occur and airway could be compromised. And breathing, look at the breathing. It should be regular respiration. If there is significant retraction, then respiratory support either in form of CPAP or HFNC could be required. Target saturation should be between 91 to 95%. Hyperoxia will lead to oxygen injury to the brain and lungs. Superoxide dismutase and oxygen free radicals are formed which damage the brain in long run. Reperfusion injury is common with high oxygen. So breathing support if needed, and circulation means your pumping of heart, your blood pressures. To maintain blood pressure, the mean blood pressure is equal to gestation in weeks. So a term baby at 40 weeks should have a mean blood pressure of about 40. Normally, you should look at the normograms, systolic, mean, and diastolic blood pressures have normograms which are there in all the books. So all this such normograms should be placed on the notice board or in your case sheets, and you should monitor as per, because every day and every week the blood pressure nomogram it changes with the gestation. So one has to look at the nomogram to diagnose hypotension in such babies. Nutrition is never to be missed out. If there is severe asphyxia, the patient is hypotensive, abnormal movements or seizures are there, autonomic instability is there. So obviously such babies cannot be fed, and such babies should be on IV fluids. But once the abdomen is soft, one sees hemodynamically stable, that is, there is no need to increase the inotropes regularly. Once the lactates are stabilizing a bit, then and the baby has passed meconium, then you can start feeding this baby. Now, such guts are already hypoxic, so it is always good to give express breast milk to such babies instead of formula milk. Metabolic workup is important. All such babies should have Glucose monitoring regularly because both hypoglycemia and stress-induced hyperglycemia can occur. Hypocalcemia is quite common. Hypocalcemia can lead to jitteriness and seizures in such babies. And vitamin K should be given to all babies, um, either in the labor room. If not in the labor room, then in the NICU. Coming on to seizures. Seizures is one more thing which can happen in parental hypoxia. So if seizures are there, um, it is straightforward HI stage 2. And how do we manage seizures? We shall read just now. Next one, please. So the clinical signs, this is very important for a clinician. We are first clinician, then we are anything else as a pediatrician, as a pediatric resident. So um, to all dear residents, one is to look at the heart rate by using the monitors. So this is the ECG which is coming over. So one needs to put on ECG electrodes on the chest and monitor the heart rate. But if there are no ECG probes in your NICU, then don't worry. You can do simply put a stethoscope on the chest, on the left, on the precordium, and count the heart rate. Count it for 6 seconds, and multiply it by 10. Pulse oximeter, you can't do clinically. You need to have a pulse oximeter to monitor. And if you have ECG leads, and respiratory rate is also shown. Like over here, respiratory rate is not mentioned. Pulse rate is coming as 171, but respiratory rate is not coming over with the respiratory monitor. Then capillary refill time has to be monitored in such babies. And either you look at the central place for capillary refill time, the forehead or the chest area is best. But peripheral perfusion is equally important. And peripheral perfusion can be looked at either in the sole or the palm, and you press the sole for about 5 seconds and then release it and count how many seconds does it take for the blanched skin to become pink again, that is to reperfuse. So if ideally it should be under 2 seconds. If it is more than 3 seconds, then perspiration is poor and such babies can be said to be in shock, and such babies definitely need NIBP monitoring. Look for respiratory distress and monitor it. If there is subcostal retraction as is evident in this baby, there are suprasternal retractions, head bobbing could be there. Look at urine output because the kidneys could be affected. And abdomen girth needs to be monitored as I'm mentioning over here. Neurological examination has to be done on such babies. So Levine stages CNS, how do we monitor the, just a minute, please. So general examination was there till now, vital monitoring. Now systemic examination, CNS, you need to monitor Levine stage 8 hourly. CVS cardiovascular monitoring should include monitoring the color. Asphyxia can lead to paleness as well, asphyxia pallida as it is called, or baby could be cyanosed centrally or peripherally. You need to monitor the heart rate. You need to monitor capillary refill time. Look at the pulses, whether they are feeble and low pulse volume is there, then such babies could be in shock. Look at non-invasive blood pressure and your pulse oximeter. Pulse oximeter is considered one of the vital signs now, in addition to heart rate, respiratory rate, and temperature. Look at respiratory score, monitor the respiratory distress, and do Downey's score or Silverman score. Downey's or the DVM score. DVM is Downey Vidyasagar Morrison score. Vidyasagar is a very proud Indian now, who became one of the leading neonatologists in the West, and we are very proud of him. Vidyasagar score, as it is called, you can read it from your books. One need to do it very frequently as per the condition of the baby. Initially, it could be required every 30 minutes or so. but once the baby has stabilized, then every 2 to 3 hours, and once even more stabilized after 3 4 days, then even 6 hourly or once per shift is enough. Abdominal girth monitoring needs to be done because such babies have hypoxic gut, and um, hypoxic gut can develop ileus and distended. You need to monitor renal output, urine output. But remember that oliguria can happen in renal failure, but also non-oliguric renal failure is reasonably common in perinatal asphyxia. So if urine output is good, don't think that kidneys are fine. Still, you need to monitor renal functions, and creatinine could, to your surprise, creatinine could be high in the range of 1.3, 1.7, or even 2. And urine output could be 3 ml per kg per hour or 4 ml per kg per hour. So minimum it should be 1 ml per kg per hour or more. Now, metabolic monitoring, blood sugars should be maintained 6 to 8 hourly for first 24 hours. If it is less than 40, then it is hypoglycemia and it is very bad. More than 145 is also abnormal, and hyperglycemia is equally bad for such babies. Hyperglycemia leads to osmotic diuresis, and such babies can get dehydrated as well. Then seizures is common, and management of seizures is of utmost important. You have to be very quick in diagnosis and then managing it. Next. A little bit of pathophysiology of asphyxia. It is a short, long question for all postgraduates. Postgraduates may, you know, want to learn at least what comes in the written theory exam, because that has to be passed separately. So with hypoxia ischemia, there is primary neuronal death. Then there is cytotoxic mechanisms come into picture, and this leads to, with cytotoxic mechanisms, can lead to delayed neuronal death. So there is initial primary neuron death, that is immediate hypoxia, which leads to neuron damage. Then second is after 24 to 48 hours, delayed neuron death can happen. So this leads to progressive worsening of neurological compromise which is there. So baby could be coming with movements, with some respiration, with even some cry, and at 1 or 2 hours, and after about 48 hours, when there is significant delayed neuron death, such babies, they become comatose and lethargic. So parents may feel, okay, we had brought the baby okay, and he has become comatose now. So is there some problem which has happened with the drugs which have been given? So one has to explain it to them a priori. That is, okay, your baby has this problem, and this is the natural course of the disease. That is, babies, they are reasonably okay or a bit preserved early on, but they may worsen over next 72 hours or so. Now, in this part, to prevent cytotoxic damage and to prevent delayed neuronal death, comes the role of a very important and a new intervention. It's not very new anymore. It is quite reasonably established intervention of hypothermia. So hypothermia, that is brain cooling or total body cooling, that needs to be, it is important to know. And because this has been shown that it helps the baby significantly in delaying the delayed neuronal death. Next. So we talked about delayed neuronal death. How does that happen?
Yeah, Amit sir, it was just to show the update on hypothermia only. So we can just run through this therapeutic
Okay.
hypothermia part.
So this free radicals which are formed and reperfusion which happens, hypothermia can minimize things. Next. So hypothermia minimizes all these. Other interventions which are there, NMDA receptor antagonist, magnesium sulfate, levetiracetam, calcium channel blockers are there. So all these, they have their role. There is always a question which comes, recent advances in management of perinatal asphyxia, and all these are things which one has to write. We also wrote the same 20 years ago in our exams, and there is not much addition other than hypothermia, even if the question comes 20, 30 years later in your exam. Cooling is, as I said, is the only new thing which has happened in last 1 or 2 decades. It is now reasonably well established in Western countries. There have been multiple trials, 11 RCTs on 1,500 babies. It is only for term and late preterm babies, that is more than 34 weeks of gestation, with moderate to severe HIE. So mild HIE, they are not subject to this because as such, almost 90-95% of mild HIE baby, they do well. Only thing, problem with giving hypoxia is that there is a time window. You have to begin within 6 hours of birth. If you delay the intervention, the effects are not there. In fact, side effects are more. So combined outcome of mortality or major neurodevelopmental disability reduces by about 25%. So RR is 0.75, which means about 25% reduction. And 95% confidence interval around this is about 0.68 to 0.83. And number needed to treat is about 7. So 7 babies you treat and you prevent major disability or mortality in 1 baby. So mortality and neuro disability both are say decreased by about 20%, you can say. Next, this is the Cochrane, and so one all as a postgraduate, you all should be aware of what is Cochrane analysis. Cochrane analysis, what Cochrane does is takes all the studies, RCTs which are done, combines them together, and gives a final result out of that. So, as a PG, you should all be aware of all the Cochranes which are there in pediatrics and in neonatology. So, Helix trial is one of the most important trials conducted. Why important for us? Because it was conducted in India, and most of the Indian centers were, and a lot of good Indian neonatologists participated in this trial. Hypoxia for encephalopathy in low and middle income countries. So we are low and middle income countries, unlike high income countries of Europe and US. Next. 400 plus participants were there.
So these slides were just to stress that, sir, there are some babies, I think for first years, they can just remember the concept that if a baby comes within first 6 hours and has some criteria like these, which have been given by NNF, then the team should think of giving the intervention if they have it. If they don't have it, then they manage with the facilities which they have. So these 2 or 3 slides were just to make them familiar with this terminology. They may not actually remember all these things, I think, at this
This is a
stage.
potential question in theory examination, and always you need to write all this for 5
Okay.
out of 5 or 10 out of 10 marks or 8 out of 10 marks. So
Yeah,
if
article is fine, but I think the
so pH is important. That
yeah,
pH
these are
should
some of
be.
the eligible criteria. It should be done. Yeah.
Yeah, so doing ABG is important. Unless you do ABG within 1 hour or soon after birth, you won't have pH or base access. And so this is one absolute requirement. Less than 7 and base access or more than -16 done within 1 hour of life. And APGAR less than 5 at 10 minutes or at least 10 minutes of positive pressure ventilation. So if you don't know APGAR, but you have done 10 minutes of positive pressure ventilation and history of acute perinatal event like abruptio hai, uterine rupture hai, cord prolapse hai, and evidence of moderate to severe encephalopathy. That is, you see the baby, and if the baby is comatose, if the baby is dull, lethargic. Next. So neuroimaging, MRI is the best uh, modality for neuroimaging. It's not CT scan. CT scan tells quite a few things. Only advantage of CT scan is it is very quick to be done. It doesn't require special monitors to be attached to the baby. But MRI is the best. It should be done.
Yeah, but I think Ashwini sir, I was in another zonal webinar, sir, simultaneously ongoing with Ashwini Singhal sir. So sir was of the opinion कि हम सबका तो नहीं कराते हैं. We don't get the MRI done in the first 24 to 48 hours. Do you get it done, sir? Amit sir, are you able to get it
No, no,
done?
no, not at all.
So yeah, the
So
students can
we
just
normally
remember
get
that
a
it
delayed
is,
MRI only. So this
yeah.
24-48 hours is basically for diffusion weighted MRI only. So
It's not,
conventional
it's for,
MRI,
yeah, it's to understand the pathophysiology, I think. It's not practically possible to take a sick baby for MRI in most of the centers. The student can just remember that MRI may be useful at term equivalent, but we also don't get it done in all the babies, sir. This
yes.
MRI for all the asphyxiated
But
babies.
again, if there is a question in your exam about neuroimaging, then you may have to mention. But clinically, most of the centers may not have MRI, and often such babies are too sick to be transported to MRI. And
Yes.
MRI takes about 20 minutes to 25 minutes to be done.
So it
And
may not be possible.
yeah, because
So
you
don't
need
tell that,
MRI
yeah,
compatible
in this
monitors,
webinar, it
MRI
was told
compatible
to get,
ventilators, which are
yeah.
very rarely available. So
Yeah, the message
conventional
should not
MRI.
be कि सबका कराना है. This should not be the message taken by the students. That is what we wanted to tell actually. Yeah. Okay. Next one. Next slide.
Other investigations only in presence of clinical pointers. So sepsis screen and blood culture to exclude in utero acquired infection during resuscitation. So most of us would get some sepsis screen done in all babies because asphyxia itself could be due to infection only. And X-ray chest to look for asphyxia lung injury, pneumothorax is a part of it, delayed transition is a part of it. There could be cardiac enlargement, which you can see on X-ray because the myocardium is at times stunned because of the hypoxia which is there. Next. Neuroimaging like CT scan. CT scan is good at showing all bleeds are very well visible on the CT scan. Subarachnoid hemorrhage, parenchymal bleed, intraventricular bleed. They are best seen on CT scan, but all bleeds are also very well seen on ultrasound. Ultrasound is a very good modality, bedside modality, which you can do focus as it is called, point of care ultrasonography. And you can find small chinked ventricles because of edema. You can find intraventricular hemorrhage. Subarachnoid hemorrhage is possible to diagnose, but a little bit more difficult to diagnose on ultrasound. And EEG also is a modality. If bedside EEG or AEEG is possible, that is very good. But if it is not possible, then whenever baby is okay to be shifted for EEG, that can be done. Next. Perinatal assessment, regular antenatal checkups are important. So high risk approach should be there, and any high risk baby mothers, like who would be the high risk mother, who is severely anemic, who has hypertension, who has PIH, who has oligohydramnios, who has cardiac disease, who has renal disease. So all these at risk mothers should have are at high risk of perinatal hypoxia, and all such baby delivery should be attended by pediatricians, and definitely, and should be conducted at a place where facility for resuscitation and facility for quick transfer to NICU is there. So timely intervention of CS should be done. You can be monitoring the patient on your CTG monitor. You could be doing your profile, which may I'm forgetting the name of the score out of 10, which you give for Manning score. And if perinatal assessment shows it is very high risk, if there is meconium stain liquor which is there, if the Manning score is poor, less than 6 or so, then it is best to refer urgently if you are not, we are at the peripheral center. And Dr.
Good
Rajiv
evening,
Thapar
Rajiv
has
sir.
asked your
Rajiv
question.
Thapar sir has joined, I think.
Yeah. Welcome, Dr. Rajiv. Perinatal interventions which
listening to
can
him.
be preterm brain protection, because preterm babies also can have asphyxia. And brain protection can be given by intraventricular antenatal steroids, magnesium sulfate in labor, delayed cord clamping. That is a very simple device with zero cost, a zero simple intervention with zero cost, which should be done in all babies. And it improves the blood pressure, it improves the hemoglobin and hematocrit. So postnatally, a lot of advantages are there. You give gentle ventilation so that pneumothorax doesn't happen, so that periventricular decomalacia doesn't happen, IVH doesn't happen. So these are the common interventions or brain protective interventions which can be given to salvage babies who are compromised at birth. So golden hour strategies. Golden hour strategy is golden hour is the first hour after birth in which intervention should be done. So delivery at tertiary care hospital should be done. Delayed. If a baby is born at suppose the PHC and the baby has to be shifted, it may take almost half an hour to 1 hour for that baby to reach, and already the golden hour is lost. So instead of shifting the baby, in utero transport should be done for the high risk mothers to be sent to a tertiary care hospital. If you are at the PHC or CHC and there is no NICU there, then refer the patient to your district hospital where NICU would be there and immediate care can be provided to this baby. But make a judgment. It should worst would be that you refer the patient and the baby, mother delivers the baby while being carried in the ambulance. So nothing can be worse. So delayed cord clamping should be practiced. Delayed cord clamping is clamping beyond 60 seconds after birth. Maintenance of normal temperature and improving admission temperature. Delivery room CPAP for all preterm babies. Optimize uses of oxygen. Oxygen is a drug and should be judiciously used because both hypoxia is harmful, we know, but hyperoxia is as harmful. It creates, scamming is there, reperfusion injury is there, hyperoxic injury is there, free radicals are formed. So judicious use of oxygen is must. Next. What are the poor prognostic markers? As soon as we do something and some intervention, if there is a problem, parents always ask, okay, doctor, will my baby be affected for long, or this is a story which will just end in next 5 days or 7 days, or it can carry even further into next few years. So poor prognostic markers are need for positive pressure ventilation for 5 minutes or more, onset of seizures within 12 hours, very early onset within 6 hours means that a significant intrauterine insult has happened. It's not perinatal asphyxia, but it is intrauterine hypoxia which is there. Refractory seizures uncontrolled with phenobarbital and phenytoin. If you have severe HIE, Levine score of more than 15, as it is called, inability to establish direct feeding by 1 week. That is important. If the bacha oral feed nahi le pa raha by 1 to 2 weeks, some say even up to 2 weeks, the oral feeding unable to take within 14 days, this baby has significant problem. Next. All neonates who suffered perinatal asphyxia to be followed up for monitoring of growth and long-term neurodevelopment, because if brain is compromised, then the growth doesn't happen. Next. All the questions we can take in the end, Dr. Pratima.
Yes, sir. Yes, sir.
Key message over here is initiation and development of hypoxic ischemic injury is complex and with multiple contributing pathways. Close monitoring and supportive management works in majority of cases. Therapeutic hypothermia established therapy other than supportive care, and different physiology acts in term and preterm infants. Neonatal seizures.
So yeah, we can take 1 minute and just, I think, absorb what was told in birth asphyxia. I think the definition is important, and in our practical settings, the definition would be based on rather the use of positive pressure ventilation I don't know how many do cord pH. They didn't answer in the chat box. So if cord pH is available, we can define as per the AAP classification. And then clinical monitoring, most of the babies, I think 90 to 95% of the babies will respond to your basic management, which Sir told: temperature, airway, breathing, sugar, CFTs, early management of shock. And some babies may benefit from therapeutic hypothermia, but that's not the end of the management. That if you don't have it, then you don't move ahead. Same with MRI. So those were the key messages that
Do
keep
we
an
take
eye
the
close.
questions related to in the chat box here itself or after
We
seizures?
can take a minute, and that will give a break also, sir. Seizures is a little shorter one only, I think, another 15 minutes or so. So I think Rajiv Thapar sir there were few questions. How to differentiate stage 1 and 2? I think that was answered. Has Sanath staging? Yeah, it was done on 35 babies only. Uh, so, but we still find it relevant, sir. I mean, of course, we don't have many parameters like EEG and all, which are mentioned there. We used Thompson's in our unit because that gives us a score and an objective assessment. What is your experience with amplitude EEG? Should NICU have cerebral function monitors? Our experience with amplitude integrated EEG is more with the babies who are on therapeutic hypothermia, sir. For diagnosis of seizures, which is the next topic, conventional EEG is the gold standard. But then the question remains, how many units can have that 12 that conventional lead EEG machine in the NICU? So the bedside amplitude integrated EEG gives certain patterns which can maximum prognosticate in asphyxias. But for diagnosis of seizures, the gold standard is still conventional EEG. So our experience is limited to babies who are under therapeutic hypothermia. We do monitor them with amplitude integrated EEG to look at the burst suppression pattern, the sleep-wake cycle and all, not otherwise, sir. Delayed cord clamping is a preventive strategy in babies, I mean, in the perinatal period itself, if the mother is referred timely. Then these are the neuroprotective strategies for preterm babies. As we summarized, that the pathophysiology of asphyxia in preterm and term is different. So DCC has been shown to have a better cardiovascular stability. In, of course, in babies who are active, sir. Still, for depressed babies, the trials are still undergoing, and perhaps still in the research mode, especially in LMICs and our units, where bag and mask, giving bag and mask with intact cord will be very difficult. Thank you, sir. Sir, one topic is left, sir. Seizures. So, so the next topic for today is neonatal seizures, and I have tried to combine, I mean, in the talk. Sir, Amit, sir?
Yes, yes, yes.
Yes, sir. Yes, sir. Please
So
continue, sir. Yeah.
in seizures, there is sudden alteration in neurological function of a neonate, that is motor, behavior, or autonomic function. So motor is evident to us, that is jerky movements of upper limb or lower limb, at times the head, the lips. Behavior could be some just changes in the tone which is there. Autonomic function could be just the color which changes, the mottling which appears intermittently. So seizure in a neonatal period is always an emergency. And all those who have read IMNCI also, the first question for a possible serious bacterial infection or a problem is, does the child have convulsions? Any baby with convulsions in emergency has to be admitted, and there is no role of domiciliary treatment of such a baby. Next. To identify neonatal seizures, you enumerate the causes of neonatal seizures, which we'll just see, and then we manage it. And subsequently, aim of all management is to stop all anticonvulsant as soon as possible, because the anticonvulsant themselves, they have side effects, significant side effects, and can alter the neurology of the baby. Next.
So can somebody describe? We can just shortly play this video. Shashank, if you click on this, just a few seconds of it you can play just to show them the abnormal movement. Can you all see the lip smacking he's doing? And there is no blinking in the eyes. And if you see the vitals at this time, there may be some changes in the vitals also. Yeah, you can stop, Shashank, I think. Sir, Amit sir, these were the 2 or 3 ones which we wanted to show.
Great. Then you have International League Against Epilepsy update on classification of neonatal seizures. And this was a very good article which had come over. Next.
So yeah, classically we used to say subtle seizures and how to define seizures. Is just to update you on the recent guidelines. The term subtle is not used nowadays. So we'll see ahead.
Subtle has been subtly removed. And
Automatism बोलते हैं अभी. So duration is not actually important. One should be actually more focused on the stereotype movement, which we just saw. The same movement occurring again and again, again and again. And this is theoretical that more than 10 seconds has correlated with seizure or abnormal movements. Yeah, it's just the definition which you should know. Next one, please. Yes, sir, please, sir.
yeah. So relative frequency of occurrence, that is, you can see the biggest circle is of hypoxic ischemic encephalopathy. HI is the most common cause of seizures in neonatal age group. Then comes infections like meningitis, encephalitis. Vascular causes like stroke could be there. Metabolic causes are as common with the hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia being the common ones. Genetic causes could be there, and there is a bit of idiopathic or unknown causes which are there. And so, yes, so HIE infections and vascular causes. I would add metabolic as well because they are quite treatable. So diagnosing hypocalcemia is of vital importance because then you can save the child being given anticonvulsant and anti-epileptic drugs. Next. The classification of seizures is based on electroclinical type. Emphasis is emphasize the key role of EEG in diagnosis of neonatal seizures. I wonder how many units have EEG for diagnosis of neonatal seizures. And the best is bedside EEG facility should be there because transporting such sick babies to EEG room is not feasible. Have implications for management and treatment of events. Be acceptable to neonatologists, pediatricians, epileptics. So there are vast number of people who are involved in care of neonatal seizures, and most do not agree to the protocols which are formed by the others. So a reasonable consensus has to be reached, and this classification should be applicable to all healthcare settings, primary, secondary, tertiary. So a doctor sitting in the periphery in the village should have a protocol of how he has to manage opposed to a person who is sitting at the level 4 and ICU, how he would manage and follow such babies.
So here also, I think we can elaborate that many units may not be. If you are awake, the students, please you can type in the chat box. Have you ever seen an EEG machine or amplitude integrated EEG in your NICUs? Those who have completed their neonatology posting as yet? No. So that's fine, I think. So we can just stress that there are 3 types: clinical only, the ones which are clinical plus ECG changes, and the ones where the facilities are available. Only EEG findings are there, but not clinical. So ideally, what international guidelines say is that all electrical seizures should also be treated, and every baby should be monitored with an
Continue
EEG.
treating
But
till
that may
all
not be
electrical
possible.
seizures also are stopped.
Yeah.
For
Next one,
practically
please.
for us, all clinical seizures should be treated, and you continue treating till all clinical seizures are stopped. because most of us don't have
Yes.
continuous
Most
EEG
of the
monitor.
studies from India also have taken that endpoint only.
Yes.
So this was the slide to show that the term subtle seizure is no more there. So now there is motor, non-motor, sequential and unclassified, and automatism is the one which is now used, sir. In
Yes.
clinical seizures, we'll stick to clinical seizures.
So yes, clinical seizures.
Next one only, Shashank.
Yeah. So subtle seizures or automatism, as it is called, are most common. Repetitive blinking, and these are difficult to diagnose at times because parents feel that this is a normal activity which is going on. Just blinking of eye or lip smacking, tongue being protruding repeatedly. So repetitive movements of mouth or tongue, purposeless movement of the limb by cycling or swimming. So if these are there, one should always label them as subtle seizures. Look at the clonic movements which are there, repetitive movement of limb or the face, tonic posturing which is there, just the arms are extended or the limbs are lower limbs are extended, which are the tonic um, seizures, and myoclonic is jerky movements of the limbs or even head, chest, it can happen. So these are the four common
Shashank, you can mute
classifications
others.
of
I think
clinical
somebody
seizures.
got unmuted.
नीचे आया मतलब कुछ और कुछ राउंड पे क्या हुआ था वो पूछ रहा हूँ
Dr. Chan.
इसका नहीं सर ने कुछ नहीं बोले थे वो माधुरी मैम बोले थे एक बार शाम को इसका इवनिंग वेट तो कम गए थे यहाँ की मशीन अरे हाँ भाई
Dr. Chandra Prakash is there. Please mute. Yeah. Okay.
Next, please.
Next slide, please.
Descriptors of motor seizure in neonatal period.
So again, each one is either unilateral, bilateral,
Yeah, either
symmetrical,
can be
or
focal,
asymmetrical.
unilateral, or multifocal and focal are important to differentiate what is multifocal. If multifocal is two or more limbs are affected, is multifocal. If for to be multifocal, it has to cross the midline as well. So if two limbs are there of an opposite side, it can be multifocal. And so epileptic spasms and are usually less seen in the neonatal period, but automatism, clonic seizures, myoclonic seizures, and tonic seizures are commonly seen in the neonatal period. And all can be classified as asymmetric or symmetric or focal or multifocal, unilateral, bilateral. So these are common. Next.
Next one, please. This slide was just to show that syndromes are now more and more identified with a lot of EEGs and genetics available now. So this was, and newborn can actually have epilepsy syndromes, the ones who are refractory actually, not responding to, and maybe associated with some dysmorphisms, comorbidities. So in those babies, we should suspect.
Yes.
Okay, next one, please.
What if EEG is not available? So everything is based on EEG, EEG, EEG. So what if EEG is not available? Observation by experienced personnel can diagnose probable or possible seizures and baby with high risk of seizures. If EEG, this is a very important classification because it asks first, is EEG available? If the answer is yes, then you look at EEG, correlates and label it because that is the best possible scenario. However, if EEG is not available, then it should be observed by experienced personnel and he should be able to differentiate between what is focal clonic or focal tonic seizure and which is probable diagnosis of seizure. And if they, because clonic and tonic are very readily recognizable patterns and so but if they are other than tonic or clonic seizures, then it would be classified as level 3, which is possible diagnosis of seizure. So probable is more likely for seizure to happen as compared to possible diagnosis of seizure. And if observed experienced personnel is not there, then insufficient evidence for seizure, it can be said.
तो व्हाट शुड रेजिडेंट डू सर? रेजिडेंट अगर देख रहा है तो क्या करना चाहिए?
रेजिडेंट
रेजिडेंट
है तो उसको क्लोनिक और क्लोनिक अगर है तो उसको प्रोबेबल सीजर मान के और उसका वर्कअप, डायग्नोस्टिक वर्कअप और ट्रीटमेंट करना चाहिए।
हाँ, तो बेसिकली रेजिडेंट को ये आइडेंटिफाई करना है कि जिटरीनेस और सीजर में हाउ टू डिफरेंशिएट, है ना, कि ग्रॉसली जिटरी हो बच्चा उसको सीजर नहीं बनाना है। तो दिस इज द नेक्स्ट स्लाइड एक्चुअली। सो
यस, तो ट्रीटमेंट ऑफ सीजर्स अगेन TABC
आई थिंक वो
आर द
जिटरीनेस
सेम
वाला
एज
एक
इन
बार दिखाना
एस्फिक्सिया।
शशांक सर, जिटरीनेस वाला एक बार दिखा दें सर कि स्टिमुलस सेंसिटिव
या
वाला जो डिफरेंस।
so jitteriness and seizures में seizures will have a fast component as slow component. Jitteriness is just continuous tremulousness which is there. Jitteriness can be induced and stopped by hand. So if the baby is moving, you hold it, it will stop. Whereas a seizure will never stop. And
हार्ट
um,
रेट चेंजेस विल बी देयर, सो दीज आर
autonomic
2 or 3.
changes, heart rate changes, yes, either tachycardia or bradycardia or cessation of respiration can occur, or mottling can occur with seizures, but will not ever
Desaturations, yeah.
happen with jitteriness. And EEG abnormality would be there in seizures, but not be there in. Then, if you examine the baby, then there would be some neurological abnormality like hypotonia could be seen in seizures, but it would be apparently normal in jitteriness. So eye or gaze movement would be there in seizures, but will not be there in jitteriness. So very simple things, just looking at it, you can tell it. A little bit of experience, 4 or 5 you see, and you would be able to identify. So message to all teachers is just don't be scared of asking your seniors and keep on asking them. You can make these days everybody has a smartphone. Any abnormal movement which is there, you have nobody to ask. Just record that event and
Yeah.
next day at rounds you can show and see this baby has this type of seizure. A movement were there. Is it seizure or is it not seizure?
And please wake up your third year PG or SR also. You can wake them up.
Wake them up. Are they sleeping?
If they are resting, you can go and wake them up. Yeah.
Okay. The next, please. So as in asphyxia, the treatment of general treatment remains the same. That is T for maintaining thermoneutral environment, A is for maintaining patent airways, P is for effective breathing. If there is distress, you give respiratory support. If there is no distress, just oxygen. And no extra oxygen to be given. Saturation should be kept above 90 and below 96, 91 to 95. And maintaining C, that is adequate circulation, very important. IV access, all babies should have IV cannula put in. Take samples, take CBC, check blood sugar, calcium, and electrolytes. And if there is a scenario for sepsis, then take blood culture as well.
So
Next.
next few slides, yeah. Step 1, step 2, step 3, practical approach है from the facility based newborn care. So please ये याद रखिएगा. Just
ब्लड
remember
शुगर
these
जरूर
steps.
देखना है, ये सबसे इम्पोर्टेंट है। अभी मैं एक पेपर पढ़ रहा था जिसमें ये आया था कि जो डेवलपमेंटल डिले वाले बच्चे हैं और MRI के अंदर उनमें चेंजेस रहे हैं, तो मोस्ट कॉमन जिसमें कॉज सर्टेन
Yes.
हो सका है, दैट वाज हाइपोग्लाइसीमिया। तो
Preventable
हाइपोग्लाइसीमिया,
है, treatable है at your level, okay? Even if you're
यस,
alone in the unit at night and you detect that second step पे ही you detect that the sugar is low, less than the cutoff, and you treat it with the bolus, it is rewarding that you will be preventing the long-term sequelae. So do not miss this stepwise approach. Always check the sugar.
prevention of hypoglycemia is very important. Hypoglycemia tends to occur in high risk category. So if there's a low birth weight babies, you need to monitor these babies. If it's IUGR babies, you need to monitor such babies. If it is infant of diabetic mother, you need to monitor such babies. So that is very important. And just doing a heel prick is good enough most of the time, but one should
Yeah.
always remember that heel prick sugars may not be as accurate, and either sugars in ABG or a lab value of sugar is the gold standard. And if you have
Hypoglycemia, yes sir. Last week detail में discuss हुआ है. I think if people have attended. So
एक वीक में भूल जाते हैं डॉक्टर प्रतिमा.
ठीक है sir.
So again, yeah. So management is constant. We have discussed this last week. Give a bolus and then followed by continuous.
Yeah, some students may be wondering ये GIR क्या है, तो it was explained last week I think in detail. Dr. Ashish Jain was
Glucose
there.
infusion rate, is it so?
Yeah, yes, sir.
Wonderful.
Okay, next one.
Next is if blood sugar is normal, check calcium, serum calcium levels less than 8, less than 7.5, uranic calcium less than 0.8 is diagnostic of hypocalcemia, and give IV calcium gluconate 2 ml per kg slowly over 5 to 10 minutes. 1:1 dilution should be there with distilled water. Don't give fast IV calcium. Always give it under heart rate monitoring, because rapid push of calcium can lead to sudden cardiac death. So do not add calcium to maintenance IV fluid. So how do you give maintenance calcium? 6 hourly?
No, this is just to manage the seizure, sir. So we just give one dose, we wait for the report, sir. So the idea is to say that abhi se maintenance calcium therapeutic nahi dena hai. It's just a first which we are giving, the first dose. And once the report is available in the next whatever 4 hours, 6 hours, then we decide accordingly, sir. So straight
If
away
you
we
don't
do
have
not add.
facility to do calcium, and if seizures are there, then there is no harm in giving low
Yeah,
calcium.
yeah. Okay, okay, sir. Okay. Next one, next slide. think सर का एक और मीटिंग भी है. Next one.
Yeah, next. Okay. Fourth step is if seizure persists even after correction of hypoglycemia and hypocalcemia, then obviously anticonvulsant drug is to be given, and still the drug of choice is the age-old phenobarbital 20 milligram per kg given over 20 minutes. So diluted has to be diluted in NS. NS is the diluting medium.
Hmm. Hmm.
So and you give it slowly over 20 minutes. Otherwise, a lot of hypotension and loss of sensorium can happen with fast push of phenobarbital, and respiratory arrest can happen at times.
Yeah, वैसे भी न्यूबॉर्न में we always teach that none of the drugs except for bolus perhaps जो हम शॉक में देते हैं and dextrose, other drugs are to be given slowly, I mean over 15-20 minutes. So same with the anti-epileptic drug. Most of them cause respiratory depression, heart rate changes, so it's important. And diluent is also important. 10% dextrose phenytoin is not to be mixed. Next one, please, Shashank.
If you dilute in dextrose and you give 5 ml or 10 ml of dextrose, then that is significant amount of dextrose which we are giving, and post uh, this bolus hypoglycemia can occur. So
Yes.
that is to be seen as well. If seizure persists or recur despite first dose of phenobarbital, you give up to 10 milligram per kg, again up to 40 milligram per kg. Phenobarbital can be given. Always uh, start maintenance phenobarbital at 3 to 4 milligram per kg per day after 12 hours of loading dose of phenobarbital. This, I think this is the standard practice at more places. Some give up to 5 milligram per kg per day in two divided doses, but the dose begins 12 hours after the bolus dose. If seizure
Yeah, next one, next one.
phenobarb, phenytoin or phospheniton, again given slowly over 20 minutes. The dose is again about 20 milligram per kg IV, and the maintenance dose of 3 to 5 milligram per kg beginning 12 hours after bolus has to be continued. Phenytoin should be mixed only with saline and not with dextrose, because it precipitates in dextrose, and it can cause side effects, and the delivery is also erratic.
Next one.
And if seizure is still persisting, then you can give either lorazepam or midazolam or levetiracetam. These are the three drugs which come as a third line drug.
So we are using, sir, I think this was mentioned in the manual, but I think their use has reduced considerably, you know.
Yeah,
Benzodiazepines ka use.
midazolam infusion.
Yeah, midazolam we give,
Not
but
usually done
lorazepam
as
and
third
diazepam are
line.
hardly.
Most of the people would be using levetiracetam quite freely as second line, if not the first line drug.
Yeah, that's coming up in the next slide. So just remember that midazolam for refractory seizures in extreme cases. Next one, please.
Diazepam should not be used for control of seizures. That is important because the preservative there can cause problems in baby. Next.
Next slide.
So which is the preferred second line
So
anti-seizure
this we
medication
wanted to
for
stress, sir,
newborns
I
with
think.
seizures?
Mm.
So either phenytoin or levetiracetam or midazolam or lignocaine can be used as a
Yes.
second line.
Just one line on this slide, just to say that the latest recommendation also says that phenytoin or Levera, whichever is the unit comfortable in. Next
The
one.
patient has cardiac disorder or hypotension, then phenytoin can cause cardiac arrhythmias, etc. Then levetiracetam is the preferred second line drug. If the baby
Next,
is
please.
on inotropes and all. This is a basic slide which basically is just a revision of what is to be done.
Yeah,
If you
it
have
summarizes. You can keep it in your units as a job aid. And the same thing which we have just explained. Phenobarbital followed by phenytoin, followed by if needed midazolam. And now Levera, phenytoin are almost equivalent, but the unit is comfortable using phenytoin, you can do that. Next one. Don't forget sugar and calcium, which are there above anti-epileptics.
optimum duration, that is something which is always controversial.
Hmm.
Transient metabolic problem like hypoglycemia, hypocalcemia, dyslipidemia, just treat the cause. And if these causes are evident, you can stop anticonvulsant drug immediately if we had given it earlier. Seizure control with first bolus of phenobarb, then no maintenance is required. You observe for
तीन ही
48
की
hours.
मैसेजेस हैं सर इसमें एक्चुअली ना, यही है कि मेंटेनेंस नहीं देना है अगर सिर्फ लोडिंग फिनोबार्बिटॉन दिया है। सेकेंडली है कि अगर सेकेंडरी सीजर है, जैसे सेकेंडरी टू मेनिंजाइटिस है, हाइपोकैल्सीमिया था, हाइपोग्लाइसीमिया था, तो आपको तुरंत ही बंद, यू हैव टू स्टॉप इट इमीडिएटली, आई मीन यू नीड नॉट टेपर इट। Early stoppage is now recommended, so irrespective of whatever EEG, MRI, वो सब जरूरत नहीं है, so you have to stop it as early as possible, possibly before discharge itself, neurological status normal है तो।
So seizures control with multiple drugs, then start maintenance phenobarbital. Um, but, and so if multiple doses of phenobarb are required, then you continue for continue maintenance and stop it once seizure free for 48 hours.
Hmm.
If multiple drugs are given, stop phenytoin first because it is a bit more
The one
toxic.
which was added last, that should be
Yeah,
stopped first.
good. So that was added last is stopped first. So if you have given phenobarb, then phenytoin, and then midazolam, the first stop midazolam, then stop phenytoin, and then you stop phenobarbital. If neurologically abnormal at the at the time of examination, then you continue oral phenytoin for a month or so, and then review neurological examination EEG at 1 month and again reevaluate. Next. Is the newborn, if the newborn has seizures and is controlled on current anticonvulsant management, when should the medication be discontinued?
So the same one line only, this highlighted one we wanted to say that this should be discontinued before, regardless of any MRI EEG. So the message is that again EEG MRI is not needed to stop the anti-epileptic. Stop it as early as possible if the baby is seizure free for 48 hours.
Great.
Next.
Role of
So
EEG,
this we have
obviously.
covered mostly, that
Yes.
conventional EEG is the gold standard. Yeah, next one please, ये तो picture ही है. Next.
AEG, it has gained a lot of popularity now, and it is many guidelines are recommending continuous use of AEG, and abolition of seizures on AEG is currently the standard of care, and you should give target of anticonvulsant drug is to eliminate all electrical seizures on AEG, and AEG which gives raw trace are considered to be good. Next. Conventional EEG remains the gold standard. One should not forget that. But most of the units can't have a conventional EEG, and amplitude integrated EEG is to be used bedside. So the key message here is all neonatal seizures occur in onset. Update nomenclature based on motor and non-motor semiology is there. For diagnosis, EEG has a stronger role. Phenobarb remains the drug of choice. Levetiracetam is the close second line along with phenytoin. And early stoppage of anticonvulsant is vital.
I think
All
it was very
focal in
positive
onset.
lecture.
Yeah, this
Thank you so much, Amit sir. I think both the topics were quite lengthy and exhaustive. The recording will be available, but those who have joined, they can interact and ask questions. Any questions from anybody? Either in the chat box or unmute and ask, or else we call it a day. Either everything is clear, Amit sir, or nothing is clear. Yes, sir. Yes, sir. Good evening, sir. Rajiv sir. Yeah, I'll be there, sir. I am
are
getting 2 more DM students also with me, so they will be observing and helping us out for
okay,
setting up the
great.
stations.
That is good
So
because
Sushma
you
ma'am
will
has
be the
asked me to
pillar. We
take
have
them along.
tried to make the things easier, but you will still remain the pillar. And probably Dr. Amit has to send Dr. Priyanka in time because she was thinking of coming at 11 o'clock. I said, no, please come in time so that we all start the sessions. So probably Dr. Amit will spare her from Newtima Hospital class.
definitely
Okay, sir.
Dr. Rajiv.
Mannequins.
Definitely Dr. Rajiv. Sure.
Thank you. Thank you, sir. Nice.
I have to take leave, Dr. Pratima.
Thank you, sir. I think there are no questions. We are also leaving. Thank you so much. Good night, everybody.
Right. Thank you.
So thank you everyone for your valuable insights. With all your permission, if there are no further questions, we are signing off for today. Till then, goodbye. Take care.